members from level 400, both weekend and regular class. Today, we should have done the other part of the cholinergic system, but due to our new members and participants, we would like to move on to a new topic, which will be a fair ground for all of us. So today, actually, we've done GIT pharmacology. So this is just to let our newcomers know that we have treated topics on uh, GIT pharmacology, and then we move on to respiratory pharmacology. Please, Malik, mute yourself. And we moved on to study the overview of the autonomic nervous system, and then which is all under the cardiovascular pharmacology. Today, we will be looking and treating at this topic, hypertension, okay, using antihypertensives as treatment. So hypertension, we all know that mostly is as a result of high blood pressure. And here in this case, we have the systolic blood pressure being more than 140, whilst the diastolic blood pressure being greater than 90 mmHg. Please remember that for our exams, I'll be asking questions on drugs only, okay? So the pathology part of my slides are not necessary. Although many patients have no symptoms, chronic hypertension can lead to heart disease and stroke. Now, due to the high blood pressure, when this blood pressure is high in soft areas of our head, like in terms of the brain, it can, burst and then cause stroke. And around the world, it is these top two diseases cause death. The heart disease and stroke cause death in the whole world. And hypertension is also a common risk factor in the development of chronic kidney disease and heart failure. So here in this case, like I said, when the blood pressure rises at soft parts of the body, normally it can cause havoc. So in the kidney, you could see that the pressure becomes so high and then could lead to the development of kidney diseases. Also, for the heart failure, the heart would find it difficult to pump blood throughout the whole body. Now, the incidence of morbidity and mortality significantly decreases when hypertension is diagnosed early and is properly treated. Here in Ghana, there are a lot of people having this disease, okay? But due to its no symptoms shown, normally the disease is not diagnosed early, okay? And therefore, treatment, it doesn't requisite treatment, or due to its inability to identify what disease condition it is. So here I have a table showing the various classification of blood pressure. So ideally, human blood systolic pressure should be 120, whilst the diastolic should be 80. Okay, and it's being said that blacks actually should have high blood pressure than the whites. And because largely our food mostly contains salt, so we talk more about that. Okay, so here are some of the ranges to consider someone as pre-hypertensive or stage 1 hypertensive patient or stage 2 hypertensive patient. So 90% of patients have essential hypertension. We are on etiology of hypertension. And here in this case, we mean people don't even know what causes this hypertension. And here are some of the risk factors of hypertension. These include family history of hypertension. So if your family, you have a brother or sister or parents having this disease, obviously, it's likely that you have that based on certain genes, okay? Also, hypertension have been shown and reported to increase with age. And also, it has been said that it is much more decreased with people who are highly educated and are earning income. So what does this mean? You know, as we age, a lot of cholesterol are built up in our blood vessels, and this narrows the blood vessel or the passage of blood. And here, whenever there is narrowing of blood vessels, there is an increase in pressure, okay? And I would have set an example, but since we have new members here, I will try as much as possible to withhold some examples, and then as they get to know how my teaching principle is, then obviously I'll start sharing some examples. So here, in the non-Hispanic blacks, there is a higher incidence than the non-Hispanic whites and Hispanic whites. Actually, this study, I don't know who did that study, but I don't believe it, even though you have to accept that in blacks we have more of these cases being reported. So indirectly, are they trying to tell us that due to our low level of education and income, that's why blacks have more of these cases? Well, it has been recorded, so uh, it's good for you to know. Now, aside hypertension, there are other diseases which may occur concomitantly with um, hypertension. So we have diseases such as diabetes, obesity, or disability status. Also, we have some environmental factors such as stressful lifestyle, high dietary intake of sodium, and then smoking. So diabetic patients, if you have that kind of disease, diabetes, and sometimes those people who are plump in nature, sometimes they do have cases of hypertension. Now, let us talk about how, let me move this up. Okay, so let us talk about how hypertension is being controlled in our body. Mind you, there are two mechanisms that play a major role in raising your blood pressure. One is cardiac output. So this actually talks about your heart's ability to push or pump blood out of it and then into vessels. And then the second mechanism is the peripheral resistance. That's in the vessels, you know, whenever there is a resisting activity, okay, against the blood flow, it normally reduces blood pressure. And that will trigger a reflex mechanism. So here, one of the mechanism which controls that is the baroreflexes. Okay, so this, with the baroreflexes, impulses are sent to the cardiovascular centers in the spinal cord. That's when the body detects low blood pressure. As soon as your body detects low blood pressure, your barrel reflexes have to react, okay? And it will signal the cardiovascular centers in the spinal cord, telling them that the blood pressure is low. If obviously you've seen that people whose blood pressure is low, obviously, Kweku Amwa, please can you tell Kweku Amwa to mute himself? So barrel reflexes quickly reduces blood pressure. So I was sharing an example where someone with low blood pressure would start feeling dizzy, okay, just because blood could not ascend to parts of the brain. And in that case, the person can collapse. And it's just a homeostatic mechanism, just like you running and sweating, okay, just to cool down your body. Here you collapse, and in that case, you lie down flat, and that will ensure blood movement, to and fro from your legs to your head. But while standing, the blood is going to move against gravity, and therefore it requires higher higher blood pressure to move this blood towards certain parts of the brain. So we have the barrel reflexes playing a key role, and we have the renin angiotensin aldosterone system. This kind of system is located in our kidney, okay? And most antihypertensive drugs, which lower blood pressure, have been designed to target cardiac output and also decreasing peripheral resistance. So please, under normal circumstance where we have low blood pressure, we have the baroreflexes and the renin angiotensin aldosterone system trying to play a role to raise your blood pressure, okay? However, when the blood pressure is too high, that's where we employ antihypertensive drugs to come in to lower the blood pressure. I hope it's clear. Trying to move the slide. Okay, so we have some treatments here. So the goal of treatment is to reduce cardiovascular and renal morbidity and mortality. Okay, and current recommendation are to initiate therapy with thiazide diuretic, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, or calcium channel blockers. So these are drugs that are recommended in the treatment of hypertension. Now, I told you about, so this part will actually worry our level 400 and regular and weekends, but I'll try to make this simple a bit. So we all know the sympathetic and the parasympathetic system. During sympathetic activity, there's always flight, fight or fright. And it's just, you can liken it to you meeting a lion. What happens? Your heartbeat rises, your pupil dilates just to make sure to see whether you are really seeing a lion or a dog, okay? And also secretions are reduced, okay? There are no secretions. So for the sympathetic activity to occur, your heartbeat rises just to pump more blood, okay, to certain parts of the body to initiate the flight. And for that to occur, for that sympathetic activity to occur, we have your alpha beta adrenoceptors of the neurons. So we have the alpha 1 and beta 1. Actually, I'll take you through the level 400s, please. I'll take you guys through, but this is just for you to follow up and understand certain things, that we have alpha and beta receptors, and these plays a role in the sympathetic nervous system or sympathetic activity. Okay, so we have beta 1, which is specially located in the heart, and alpha 1 on smooth muscle. Okay, and when these two are triggered by something we call a neurotransmitter, and for the level 100, we've learned something about the norepinephrine. Okay, the body produces norepinephrine on its own. So as soon as this norepinephrine binds to either the beta 1 or the alpha 1, increases cardiac output, increases venous return, and then increases peripheral resistance, leading to an increase in blood pressure. So this part occurs in the sympathetic activity. That only occurs when you are scared or afraid and you want to run away from something. Okay. Now, so aside the heart and smooth muscle, on the kidney, something is triggered. So we have beta 1 adrenoceptors on the kidney, and that one is also triggered by norepinephrine. Norepinephrine is the medium of communication. Oh, what happened? Okay, norepinephrine is the medium of communication. So as soon as norepinephrine binds to beta 1 adrenoceptors on kidney, what does it do? Raises the levels of renin. And this renin is converted to angiotensin 1. Please, this part is a little bit wide. So I intentionally remove certain things out of it so that we all get the whole understanding. So renin will be converted to angiotensin 1, and then angiotensin will be converted to angiotensin 2 by an enzyme called the angiotensin converting enzyme. That enzyme only converts angiotensin. So it's called angiotensin converting enzyme. And this angiotensin 2 would then increase the level of aldosterone. Now, aldosterone, oh, please, who is writing? Edmond. How can I stop people from having access to my slide? Nick, can you help? Okay, disable annotation for others. All right. So I've just disabled annotation for others. Okay. But I hope you all understand. If you don't get anything, please signal me so that I can go over. Actually, I shouldn't be teaching this today, but I don't know. I have to do something for the level 100 so that we all start from the same parts. So we have renin. So please remember this. The kidney, beta 1 plays a role there. Alpha and beta. So beta 1 is found on the kidney and the heart, and whilst alpha 1 is found on the smooth muscle. And whenever you are scared or anything, the norepinephrine, which is an endogenous ligand, it comes and binds to these receptors. And look at the dangerous things it causes. It increases your blood pressure. On the kidney side alone is very terrible. What it does is it increases renin. Renin is then converted to angiotensin 1, and with the help of angiotensin converting enzyme, it is converted to angiotensin 2. And this angiotensin 2 will increase the level of aldosterone. And what the aldosterone does is that it increases sodium and water retention. So it builds pressure in the blood vessels and indirectly increases blood volume. Okay, it increases blood volume and then for goes and attack the cardiac output, and before you realize there's an increase in blood pressure. Okay, now to counter that effect, what do we look at? So we either block angiotensin 2 receptors, that's here, using blockers. And please, the blockers we use are mostly Satans. And you know that Satan, they always block things. Your opportunity comes, they block. Everything that is good, they always block it. So it's a way to help you remember. And please, I forgot something here, that as sodium, wherever salt goes, water immediately follows. So even if you've built before, you can see some cracks on the wall. Yeah. And before you realize, they'll tell you that it's due to salt. It's because wherever salt goes, water follows. So automatically, when there is heat or high sunlight, it causes expansion and contraction. Before you realize, it has led to cracks in your walls. Likewise, in our body, wherever sodium goes, water will immediately follow, and therefore it can build pressure in your body. So to block those things, you use angiotensin 2 receptor blockers, okay, to block this action. So it means that this part is then cut off, okay. So we have candesartan, losartan, irbesartan, valsartan, okay. So please try and keep these in memory. However, the key word here is sartans. All right. So we move on to the angiotensin converting enzyme inhibitors. That's that enzyme that converts from angiotensin 1 to angiotensin 2 here. We have drugs for it. It normally uses pro. Okay. So we have captopro, lisinopro, enalapril. We have ramipro. Okay. So it's either you block this side. We have designed drugs to block only this side. Okay, so that's one way. Now you can also block the main, substrate, which is the renin, and we use aliskiren to block that. Okay, so it inhibits renin, and therefore this cascade is then cut off. Please, if you don't understand anything, just let me know. Yes. So this is just a summary of these drugs. You remember I said epinephrine have to go and bind to beta blockers to exacerbate your sympathetic nervous system and therefore increase your heartbeat. So there are drugs designed to block these beta receptors. And here in this case, we use beta 1 receptor, because beta 1 receptor, they say we have 10 minutes. So please, when it ends, I'll reshare a link so that we all join again. I hope it's clear.
Right.
Yes, sir.
Let's go.
Yes,
So
doc.
with the beta receptors, we use blockers. Okay, so there are so many blockers, but it's always end with lol. Okay, so acibutolol, atenolol, bisoprolol, esmolol, cavidolol, metoprolol, nadolol. Please just be smart about it, and keep some timolol. Mm? You'll be surprised to see timolol in your exams. And I'm sure if you have a friend called Tim and you see timolol in your exams, I'm sure it will help you select that. Also, we have some diuretics, mm, amiloride, metolazone, spironolactone. So please, these drugs are for diuretics. And remember, I said treatment of antihypertensive, the recommendation is to start with diuretics. So you know that. Now with the diuretics, we've got types. We've got thiazide diuretics, okay? We've got loop diuretics, and we've got potassium sparing diuretics.
Yes, please, I have a
All these
question.
drugs, come again.
Please, I have a question.
Yes, can you ask?
Okay. So I want to know the role angiotensinogen plays in the renin aldosterone, because I didn't hear. I don't know. Maybe I wasn't getting this clear, but I didn't hear how it works, because from renin we said the renin will be converted to angiotensin 1, but I didn't hear any angiotensinogen.
Yes. So all I'm trying to say is that from the renin, is called, well, we will treat it in the subsequent slides. So you just hang on. That part, I cut them off. Do you get it? So it will come in the subsequent slides. So you just take your time. For now, my concern is for you to know the drugs. Okay. So just let us focus, and you see it in the coming slides. I'll go into details. Okay, don't worry. So we have the beta blockers here, and we have the calcium channel blockers being amlodipine, clevidipine, felodipine, and verapamil. Okay, so verapamil is likely you see it in your exams. You also have nifedipine too as well. So please note that these drugs, sometimes a patient can combine 3 of these drugs. And that can, and the whole issue is that because we can't accurately diagnose what kind of or we can't diagnose what is causing the hypertension. No, like I said, you don't know whether it's beta blockers or alpha blockers or calcium channel blocking. Okay, because wherever calcium is, please remember there's always contraction. So you blocking calcium, the influx of calcium, can also help prevent the cardiac output. Okay. All right. So some treatment strategies in concomitant diseases. So if you have hypertension with high coronary disease risk, you start with diuretics, then beta blockers, and then you give the angiotensin converting enzyme inhibitors, and then calcium channel blockers. If you have with diabetes, you have the diuretics, the ACE inhibitors, the ARBs, the calcium channel blockers. If you have recurrent stroke, we have diuretics and then ACE inhibitors. Please try as much as possible to keep these codes in those eating, please. Isaac, you are enjoying, we know, but I've not eaten, so please don't let me salivate this evening. All right, so we move on into details a bit. So we have diuretics. Now, the initial mechanism of action of this drug is based on decreasing blood volume, and it ultimately leads to a decrease in blood pressure. Like I said, if the blood volume is increased, automatically your blood pressure would also be increased. It just acts like a rubber hose connected to a tap water. Whenever there is high blood volume, the pressure alone is high. Okay, that's why. So you can liken it to our fire service. They always complain they don't have water. So you could see that when they are trying to off a fire, it's always a problem in our society. They wait for the things to finish burning before they come in, because they will tell you that they are now filling with water to build pressure. Okay.
Okay.
Now, please note that low dose diuretic therapy is safe. Let me try and mute the background.
Alex, you are
Nyakwa
disturbing all of
Alexander.
us.
Alexander, please.
So you give low dose diuretic therapy, which is safe, inexpensive, and is very effective in preventing stroke, heart failure, and myocardial infarction. However, routine serum electrolyte monitoring should be done for all patients receiving diuretics. Otherwise, as you are trying to remove these ions from your system, it will lead to the reduction of potassium, and normally we call it hypokalemia. Mm. I'm sorry, this slide, I prepared it long time ago, but I've not taken my time to go through myself. But uh, so please note that hypokalemia was missing here. But I've said it, so you would answer questions on it if you see it. So for the thiazide diuretics, when taken in, can reduce sodium and water retention, which automatically reduce blood volume, and then automatically reduce cardiac output as well as peripheral resistance, and together decrease blood pressure. So we have some thiazide diuretics such as hydrochlorothiazide and clothalidone, which lowers blood pressure initially by increasing sodium and water excretion. Okay. And this causes a decrease in the extracellular volume, resulting in the decrease in cardiac output and renal blood flow. Like I said, everywhere sodium goes, water will follow. So if it is excreting sodium, automatically water would have to follow during this process. However, thiazide diuretics are not effective in patients with inadequate kidney function, and patients with will require loop diuretics. Now, okay, so I place it here. So thiazide diuretics can induce hypokalemia. That means you wouldn't you'll be deficient of potassium, okay, and there is in plenty urination, okay, and to a lesser extent, we have hyperglycemia in some patients. Now, the loop diuretics act promptly by blocking, okay, sodium and chloride reabsorption in kidneys. Please note that for the thiazide diuretics, it helps with